This lecture is part of the St George's Critical Care GETIT Echo Education. I'm going to talk about aortic valve disease in critical care echo. And during the talk, what I'd like to cover is the anatomy, first of all, the imaging planes that we use for imaging the aortic valve, the kind of aortic valve pathology that we can see in the intensive care setting, and red flags that should alert us to the need for referral for formal scanning. If we start off having a look at the anatomy, the aortic valve is a tri-leaflet valve, which in this image here you can see is very closely related to the mitral valve. And that close proximity is the reason that infectious disease, for example, often spreads between the two valves very readily. The tri-leaflet valve again, anterior is uppermost in this image, and that is the right coronary cusp, the most anterior of them, and the left and the non-coronary cusp, which is related to the atrial septum between the left and right atria. Viewing the valve from the ventricular side, we can see how closely related the aortic valve is here to the mitral valve, and the boundary between them forms part of the fibrous skeleton of the heart. So there's fibrous continuity between the two valves. And also from this view, we can see that the lines of attachment of the leaflets to the ventricular outflow are actually curves. So there is actually no structural ring-like annulus, but in fact there are three curves of attachment of the leaflets. So we're looking from the left atrial side. Here is the mitral valve, the aortic valve, and we can see the right coronary ostium there. And anterior to the aortic valve is the pulmonary valve. Of course, the coronary arteries arise from the sinuses of Valsalva of the left and right coronary cusps. So here's your left main stem coronary artery dividing into the LAD and circumflex, and here's the right coronary artery arising anteriorly off the aortic root. Having a look now at the imaging planes we use for looking at the aortic valve, often the first imaging plane that we get in our transthoracic echo sequence is a parasternal long axis view. And in this view, we align our index marker on the echo probe to be pointing up to the patient's right shoulder. And that's because what we're doing is aligning our ultrasound plane with the direction of outflow from the left ventricle through the outflow tract and up into the ascending aorta here. And in this view, we'll see most anteriorly the right ventricular outflow tract, which is anterior to the aortic valve. And we can see the LV outflow tract and the mitral valve, left atrium, the most posterior structure in the heart. Looking a little bit from the left side there, just to open up these structures, and we can see that in our ultrasound image, the relationship between the sizes of the RV outflow tract and the LV outflow tract behind it, which is here, and the left atrium, roughly a third, and a third, pretty well equal in size. Here's a real parasternal long axis view. We can look at the leaflet morphology and motion in this view. We can look at the size of the left ventricle, and of course we're always interested in ventricular function. And of course that aortic valve disease may have some bearing on right-sided heart function if the patient has pulmonary hypertension. If we're focusing on the valve, what you can do with your echo machine is zoom in so that we can see the leaflet morphology in motion in a little bit more detail. Rotating the index marker so that it's pointing towards the patient's left shoulder, we then develop a parasternal aortic valve short axis view. And in this plane here, we cut through the leaflet tips of the 3 coronary cusps. So the aortic valve, you can see here, is right in the center of the heart, and anterior to it is the right ventricle. Here's the right ventricular outflow tract, the pulmonary valve, and your main pulmonary artery. We're just seeing the start of the main pulmonary artery there. A real parasternal aortic valve short axis view. We can see the aortic valve in the center of the image here. Over here we can see the right ventricular inflow. So we're seeing the tricuspid valve here, often really well aligned if we want to measure the flow velocity of tricuspid regurgitant jets. And again, if we want to, we can zoom in on the image to examine the valve a little bit more closely. So we have here the most anterior leaflet is the right coronary cusp, and we have the left and the non-coronary cusps. And just going out of our view here is the atrial septum. If we want to measure the velocity of flow through the LV outflow tract in the aortic valve, we need to image it from the ventricular apex, because that way we can align our ultrasound cursor with the direction of flow. So starting off with an apical 5-chamber view, we developed this by starting with a 4-chamber view and then lowering the tail of the ultrasound probe so that the plane of ultrasound elevates to include the left ventricular outflow tract, and we just see here the aortic valve coming into view. And you can see here that the alignment for the measurement of flow velocities through the valve is pretty good. A real apical 5-chamber view. So the 5th chamber is the LV outflow tract. And finally, an apical 3-chamber view. Again, very useful for applying a Doppler cursor and measuring flow velocity across the LV outflow tract, which is here, and the aortic valve, and into the ascending aorta. So a 3-chamber view with the index marker on the ultrasound probe pointing up towards the patient's right shoulder. So how do we assess the aortic valve, and what are the principles of how we go about it in the intensive care setting? First of all, we need to start off with an accurate 2D assessment of the valve, and not forgetting to have a look for all the associated features and the sequelae of aortic valve disease. So we're not just looking at the valve leaflets and their motion, we're also looking, for example, in a patient who has aortic stenosis, for left ventricular hypertrophy and the inevitable diastolic dysfunction that goes with that. In a patient with aortic regurg, whether they have ventricular dilatation and also consequent mitral regurg and left atrial enlargement from either aortic stenosis or regurgitation. And in both cases as well, signs of pulmonary hypertension. So with chronic disease, pulmonary hypertension will give rise to right ventricular hypertrophy and potentially longer term to right ventricular failure. We'll use colour Doppler inspection to confirm the diagnosis that we've made from our 2D examination. And remember that actually we should have been able to infer quite a lot of hemodynamic information just from looking at the 2D structure and motion of the heart before we even apply colour Doppler to look for jets or even measure the velocity of flow. And the principle at a FICE or EFICE level of echo study is that we are ruling in pathology rather than excluding it. And of course, as soon as we have any concerns or any of our classic red flags come up, our action is to refer the patient for an immediate diagnostic formal scan. So how can the aortic valve really contribute to cardiogenic shock? And in a shocked patient, we might see it as a result of aortic regurgitation or aortic stenosis. We might also be examining the aortic valve in a patient with sepsis of unknown cause, because of course we're looking for infective endocarditis, which is a rule-in diagnosis. Kicking off with aortic regurgitation. If a patient has acute severe aortic regurgitation, the sequence of events is that they have a sudden acute volume loading of the left ventricle, which dilates and ultimately fails. And we see this in critical care, primarily as a result of infective endocarditis. So there's a image of a simulator model of infective endocarditis, and we can see it's actually quite a destructive process. So we may see destruction of the leaflets, we may see holes in the leaflets, and the thing that we see most easily, I think, is the vegetation. So in this image here, the vegetation is quite large. They're mobile structures, so when the ventricle contracts, this vegetation we can see flying up into the aortic root, and then in diastole it drops back into the LV outflow tract, causing aortic regurgitation. I'm sorry, that one's not playing. We can see though on the still of this image that there's actually a vegetation here. So this is in diastole, vegetation occupying the LV outflow tract. And if we put colour onto that image, we invariably see aortic regurgitation. In this example here, it's pretty mild. We can eyeball assess the severity of the regurgitation by looking at how much of the diameter of the aortic root, of the LV outflow tract, the origin of this jet occupies. And this is occupying less than a third of the diameter of the outflow tract. And so we would classify that as being mild. So mild is less than a third, moderate is 1 to 2/3, and severe is more than 2/3 of the diameter of the LV outflow tract. Here's a patient with severe aortic regurgitation. So we have a turbulent jet in diastole. In fact, there's colour in the outflow tract all the way through the cardiac cycle. So that smooth coloured laminar flow in systole is followed by a mosaic of colour as the regurgitant jet pretty well fills the LV outflow tract. So that is severe aortic regurgitation. I'm just freezing the image in diastole there. And you can see that that turbulent jet occupies the entire diameter of the LV outflow tract. If we have a look from the apex, so we've got here an apical 5-chamber view, and we can see a jet that is coloured predominantly red occurring in diastole, and that's the aortic regurgitation. So in systole, when blood's flowing away from the apex, it's blue, and in diastole, the regurgitant jet, which is flowing towards the probe at the apex, is red. So that's your regurgitant jet. Acute aortic regurg can also arise as a result of an aortic root dissection. And in this image here, you can see the dissection flap, intimal tear quite close to the sinotubular junction here, quite a common place for it to occur. And we might see this flap prolapsing through the aortic valve and causing acute aortic regurgitation. Just a little bit closer up. And on the ultrasound image, we see this flap as an extremely mobile linear structure in the aorta. So red flags, when should we be triggering a more formal comprehensive examination? Firstly, obviously, if we see a dilated aortic root or a dissection flap visible in the ascending aorta or an aortic root. If in the case of endocarditis, we see visible destruction of the aortic leaflet tissue, or if we actually see a space between the leaflets, if we can see that they don't coapt in diastole, that invariably means that the AR is severe. If we see a mass on the valve, which is most likely to be a vegetation, but there are other masses that we can see there, we should trigger a formal scan. And of course, if the base of the jet fills more than 2/3 of the alveoli, in other words, it's severe. We often just eyeball the size of the jet going back into the left ventricle to grade the aortic regurg. If it reaches the papillary muscles in the left ventricle, that's also severe aortic regurgitation. Moving on now to aortic stenosis. Acute severe aortic stenosis can cause a sudden loss of cardiac output and cardiac arrest. And the causes of acute problems in aortic stenosis occur when we can see thrombus forming on a prosthetic valve. So if we have a mechanical aortic valve prosthesis in a patient who's inadequately anticoagulated, thrombus will form on the leaflets of the valve and obstruct it. So in this image here, this is a St. Jude bileaflet mechanical valve, and the leaflets are closed. You can see the semicircular leaflets are resting against the annulus there. And when the valve opens, they fly open like that to be parallel in the center of the valve so that blood can eject past them. So if the patient forms thrombus in this valve, then one of the leaflets can stick in the closed position, and that would cause an acute stenotic event. Having a look at a prosthetic valve with echo, a mechanical valve causes a lot of artifact. So in the simulator image here, we can see a lot of reverberation, which just goes straight down into the far field. It's been generated by the very echogenic metallic structure of the prosthetic valve. And that can make it really difficult to assess a prosthetic valve. Especially from a parasternal position, because this artifact going across the LV outflow tract makes it hard for us to look at regurgitant jets in the outflow tract. Looking from the apex can give us a clearer view. We need to remember that when we image mechanical valves, that they do have built-in aortic regurgitation. So because the foreign surfaces of a mechanical valve are by their nature thrombogenic, the valves are engineered to have a constant flow of blood across the artificial surfaces. So in diastole, when the valve is closed, you will see little tiny jets. You can see this small little flame of red coming back into the outflow tract, which is called a washing jet. And these small jets of blood wash the leaflets and prevent thrombus formation. The important thing about them is that they always arise within the annulus of the prosthesis. So if you see a small jet going around the annular ring of the prosthesis, that's not a washing jet, that's a paravalvular leak. So you can get sudden aortic stenosis if a prosthetic valve thromboses. But we do also in critical care see patients who have chronic severe aortic stenosis who have decompensated, and they present with left ventricular failure. The most common aortic stenotic etiology in our practice will be senile calcific aortic stenosis, which is shown here. So we see calcification in the bodies of the valve leaflets, and that limits the valve motility. And on echo, the calcium in the leaflets is extremely echogenic. And a bit like the metal in the prosthetic valves, that very echogenic calcium generates both artifacts, so we get reverberation, but we also get shadowing in the far field. Anything beyond a big clump of calcium is quite difficult to see. Again, that makes the valve quite difficult to assess. So what does it look like on colour flow mapping? Flow through a normal aortic valve. So this is a parasternal long axis view, and blood is flowing from the left ventricle through the outflow tract, the normal aortic valve, and into the ascending aorta. And the flow through that orifice is fairly uniform in colour. It changes from blue to red because there's a very subtle change in direction here. But you can see within the blue section and within the red section that the colour is fairly uniform, and that represents laminar flow. In a stenotic valve, however, the flow through this very narrow orifice is turbulent, and what we see is a great mosaic of colour that flares out into the ascending aorta as the valve opens to a very small extent and blood accelerates past it. Just a picture of a real aortic valve in closed and open positions. I'm always surprised that actually the orifice of this tri-leaflet structure is not actually triangular, it's almost round. And we can trace that area of the round open valve orifice using our echo machines. So on the simulator here, what I've done is just trace the area of the leaflet tips when the valve is open in mid-systole, and the machine will tell us what the area is. Normal is 2 to 4 centimeters squared. Severe aortic stenosis is when the area is less than 1 centimeter squared. There is a bit of danger in doing this because you really need to have your tracing done at the level of the leaflet tips. And if you're not at the leaflet tips, you can overestimate the area of the valve. And again, we commonly see calcific aortic stenosis, and that calcium really, the shadowing caused by the calcium makes it virtually impossible to trace an accurate valve area. We can also quantify the aortic stenosis using spectral Doppler. So if we have our probe down at the apex in either a 5 or a 3 chamber view, we can measure the velocity of flow across the aortic valve, and from that we can calculate the gradient. So we're using the modified Bernoulli equation, which normally is an extremely long, complicated equation, but for the purposes of echo, we say that we boil it all down to be that the gradient is equal to 4 times the velocity squared. So in this image here, I think the peak velocity is measuring at about 1 meter per second, 100 centimeters per second, and we do our calculation in meters per second. So peak velocity of 1 meter per second gives us a peak gradient of 4 times by 1 squared, which is 4 millimeters of mercury. We say that the aortic stenosis is severe if the maximum velocity is more than 4 meters per second. So for those of you who are not familiar with spectral Doppler displays, flow away from the probe is represented below the baseline. And we're using continuous wave Doppler. And in continuous wave Doppler, we have to measure high velocities, such as the velocities we see typically across the aortic valve, especially in aortic stenosis. But the machine is measuring the velocity all the way along the line of the Doppler cursor. So it's measuring flow as it accelerates towards the orifice of the aortic valve, which is why this flow envelope is coloured in. It's measuring lower velocities from lower down in the ventricle. But the peak velocity we assume is the velocity of flow through the aortic valve, because that's the narrowest point along that path from the apex into the ascending aorta. We can also ask the machine to calculate a mean gradient for us, and we do that by tracing the flow envelope. So you can see here I've traced the outline of the flow envelope, and what we're asking the machine to do is to calculate the gradient at each point along this trace. So it's calculating 4v squared for each point along the outer edge of this flow envelope, and it calculates the mean of those separately calculated gradients. And severe aortic stenosis is a mean gradient of more than 40 millimeters of mercury. So red flags for aortic stenosis are if we see a stenotic prosthetic valve, because that'll need urgent intervention. If we see very thick, bright, immobile cusps that suggest calcific aortic stenosis, and if we see a very narrow, high velocity, turbulent jet of forward flow through the aortic valve. So if we put together, there's a summary of the red flags that we need to be very aware of in aortic valve disease, both for aortic regurg and for aortic stenosis. So in summary, we've covered the anatomy, we've covered the imaging planes for aortic valve studies, what kind of things we're looking for and might see in the intensive care setting, and have summarised the red flags that should prompt referral for a formal scan.